is there anyone for who this is one of your first, second, or even maybe third CP Solvers virtual reports? I think all of the names here are very familiar names, but if there's anybody for who it's your one of your first times, would love to meet you and get to know a little bit more about you. All right, I know. I think it's a group of veterans today. Well, does anybody have a case that they want to present, a case that they've seen recently or that they've been excited about potentially presenting recently? We'd love to see any cases that you have. Doesn't have to be fully fleshed out either. It can be sort of a work in progress or a case that isn't completely solved. Anything. There's always something to learn from a case.
I might have a case.
Yeah.
I'm trying to think of the details so I can be helpful for the like HPI and everything.
Awesome.
Okay, I think I have a case, but let me just log in to make sure I have all the data correct.
Yeah, amazing. Thank you so much, Audrey. Take your time. Audrey, once you have the case pulled up, we'll ask you to introduce yourself to everybody here, and so we can learn a little bit more about you.
All right, sounds good. Yeah, I am. My name's Audrey. I am an intern. I guess it's my day off, but I had a really interesting case. I'm on SFGH cardiology right now. And I thought there were some really interesting teaching points from this one case we recently had. It's a syncope workup.
Awesome. That sounds fantastic, Audrey.
Okay, and I think that is a chief complaint.
All right.
Okay.
Well, why don't we have we got the board up, which is awesome. And I think I just saw Sharmise log on. Sharmise is here.
Oh, hi everyone. So good to see you all. Sorry for being a little late.
All right. Traffic happens.
For this. Yeah.
Audrey, we are really fired up for this. Charmaine, Audrey is bringing us a case fresh from SF cards. So we're gonna go back in time to...
Can I call Audrey as our consultant throughout the case?
Exactly. We're gonna need your cardiology help. Your expertise is far higher in cards than ours is, given your proximity to it.
I'll see what I can do, but yeah, that's very funny.
Oh, thanks, Audrey. Looking forward to it.
Yeah. All right. So this is a 60-year-old gentleman. He has a history of hypertension, HFpEF, alcohol use disorder on naltrexone, and coming in for an episode of syncope. So the story for him is that we got a call from the ED, and this gentleman had, I guess, was noticed by, he was like with his roommate. He was walking up 10 flights of stairs when he suddenly had a loss of consciousness and fell over. And it looks like he had a bit of some like myoclonic jerking witnessed by the roommate for a couple of seconds. And then kind of regained consciousness and was sent to the hospital. I think in the ED, they noticed the vital signs were stable. He was afebrile. His blood pressure was a little high, like 160s. His heart rates were in like the 80s to 100s, but nothing higher than that. I think they gave him he also had a head laceration, so they repaired it. And then I think because medicine was full, they admitted to cards for syncope workup. In terms of other labs, the tropes were like mildly peaked, but they plateaued. The lab CBC, oh, sorry, I won't mention that later. Anything else
No, Audrey, this is an absolutely phenomenal intro. And I really appreciate how you're giving us this case, sort of like the way that it would unfold if we were admitting this gentleman to the hospital. Like it feels like we're there with you, like getting the call from the ED sign out, which is like awesome, right? Like it's so authentic to how the reasoning process unfolds. I think syncope workups can be challenging because far more often than not, we don't find a cause. But one of the initial things that I always try to ask myself when I'm seeing somebody who's coming in with syncope is sort of the first branch point of being like, is this cardiac syncope or is this one of the other categories of syncope, whether it's something like vasovagal or hypovolemic, or something in that category. We're obviously a little bit biased knowing that this is coming from a cardiology service, but there's many non-cardiac cases of syncope that get the cardiology service. So I think one of the great things that I'm looking for is, are there features that we have that might suggest cardiac syncope here up front? And I think the two things that I start to worry about is one is somebody having drop syncope, right? So they're walking across the street and all of a sudden they go from upright to being out without any prodrome, without any warning signs. So there's no diaphoresis, there's no sense of the curtains coming down. That sort of like very quick drop syncope increases the probability of a cardiac event and particularly a vascular event or an arrhythmic event. The other time I start to worry about a cardiac cause of syncope is if somebody has exertional syncope, like we have here, right? If drop syncope is due to a vascular cause or an arrhythmogenic cause of syncope, the exertional syncope could easily be due from vascular dysfunction, or it could be from a valvular dysfunction as well. For example, individuals with severe underlying aortic stenosis may have decreased, or they may have such a tight valve that they can't augment their cardiac output through the tight valve to exert themselves. And so that can also lead to syncope. So right here up front, right, we have some features that tell us that there could be an underlying etiology or an underlying cardiac cause of syncope here, given that this was exertional while walking, and the fact that we have a head laceration, right? Individuals who have things like vasovagal syncope, when there is that prodrome, they may be able to gather themselves and collect themselves so that they're not in a position where they're vulnerable to head or face trauma. But when there is that quick drop syncope that comes out of nowhere, it can be really difficult to catch themselves. So the combination of a head laceration and the fact that it happened under an exertional state helps me, or I would say increases the probability that we're dealing with a cardiac cause of syncope here. And the three buckets that I think about are vascular, valvular, or arrhythmogenic. And sometimes those things can actually multiple ones can start to come together. I'm going to kick it over to you, Charmaine, for any other thoughts here on this initial awesome HPI that we got from Audrey.
I couldn't agree more, Jack. I love your approach and I 100% agree with it. I feel like one thing I always try to keep in mind is also the mimics of syncope. And Robbie put it in the chat. The one that I usually think about is like hypoglycemia, stroke, seizures. And to a lesser degree, thinking about like substances. And as Robbie mentioned, like sleepiness too. And I think the one thing to recognize is like, loss of like bladder control, myoclonic jerks can happen both with syncope and seizures. Like we see that this person was having myoclonic jerk. It doesn't necessarily mean they had a seizure. So something to keep in mind as well, but I am right there with you. I think, this is what I'll think of high risk syncope. And when you think about syncope, the thing to rule out is like cardiac etiology and cardiac causes. So can't wait to hear more from you, Audrey.
Yeah, that's awesome. Thank you so much. And I also think that learning point about myoclonic jerks was something new for me too, is that I was like, oh, is that a seizure? But I think knowing it can happen a little bit briefly after syncope was great. So in terms of past medical history, it sounds like he's actually had a few admissions for recurrent syncope in the setting, and was thought to be in the setting of his alcohol use and dehydration. They've done previous workups for him and kind of discharged and wasn't really quite sure. or they couldn't find any cause. In terms of his past medical history, he did have a pretty, I would say, significant, mostly for the alcohol use, which he used to be, he came like from like a gallon a day. I think in the last 2 years has kind of dropped down to 1 shot a day. And this is kind of in the last 2 years, he's noticed that these syncope episodes have recurred. And then in terms of his HFpEF, it was kind of a hard call. Like it wasn't like the strongest of calls in the sense it was maybe hypertension, and they got an echo for him in a recent workup that just showed an ejection fraction that was about 50%. Yeah, in terms of medications, he is on, let's see, gabapentin 600. He has peripheral neuropathy at baseline from the alcohol. He's on losartan 25 mg a day, metoprolol 25 mg a day, sildenafil. He doesn't actually take that too often, and then some multivitamins. No known allergies. Family history, he can't really recall anybody who like dropped suddenly of a heart, like and died suddenly. In terms of, yeah, so he wasn't really quite sure about that. Social history kind of mentioned the alcohol use. Looks like he did have a remote 2-year period of meth use, no IV drug use, not a tobacco smoker. Let me know if we would like the next aliquot. In terms of the vitals and exams, I think we kind of mentioned already the initial presenting vitals. His exam was notable. Let's see, he was in no acute distress. He was pretty comfortable. He was alert and talking to us. He had a regular rate and rhythm, no appreciable murmurs, rubs, or gallops. You could hear the S1 and S slightly louder than S2 at the left lower sternal border. His JVP was estimated at 9 centimeters. He had some rib tenderness from the fall, so he couldn't do the jugular reflex. No pedal edema. He was warm and well perfused. He had a soft belly. Yeah, thanks. And grossly, his pulmonary exam, lungs were cleared to auscultation bilaterally. His neuro exam, he could move all extremities. He had upper strength intact, 5 out of 5. Coordination, finger to nose and heel to shin intact, no ataxia. No tremors noted, no tongue wag. Overall, he seemed pretty comfortable and alert to us, and was able to kind of, he was alert and oriented ×4, so wasn't quite, no state of agitation. And then I guess they have HENT, unremarkable, would say moist mucous membranes. He was prepupils round and reactive to light, extraocular movements intact, so nothing focal there.
All right. Is this a good place to stop, Audrey?
Yeah, I think so.
Awesome. Thank you so much. This is fascinating to think through. I'm very excited. So I'll cover some of the background information and pass the mic to the amazing Jack for kind of his thoughts and going through the exam as well. I think kind of like looking through his background information, and the things that stand out to me. I think like when I hear syncope first, I go through my mimickers. My first pass is like thinking about cardiogenic etiologies, and then thinking about orthostasis, vasovagal. We really don't have a history for vasovagal here. And then the other, while like that is my first pass, the second pass that I like to think about when it comes to syncope is that like, okay, what is syncope? Is a transient loss of consciousness. So basically, you have a brief drop in your blood pressure. And the two components of that, like whether you had a decreased cardiac output or you had decrease in your systemic vascular resistance. And the thing that goes into your systemic vascular resistance is like whether you had a decrease in your sympathetic tone or increase in your parasympathetic tone, right? So as I go through like people's history, I try to figure out like, hey, is there any component that can contribute to that? Because sometimes, yes, we have one etiology of syncope, but you can have two things that working with you, right? Like if you're hypovolemic and you have blood pressure medications on, you're more likely to be syncopizing secondary to orthostasis. So are there like different factors that are contributing? So in this patient, with heart failure with preserved ejection fraction, it's really helpful to know that is like maybe a borderline call. So and hope I'm assuming that, if he's had a recent echo that didn't show any valvular pathology or anything else. The other thing to think about is like alcohol use disorders. Alcohol use can cause the autonomic dysfunction. So does he have any component of like underlying orthostasis that with like dehydration, with like other medication can lead to syncope? So like getting orthostatic vital signs would be helpful. And the other thing in terms of his medications, but like losartan alone, I wouldn't think causing syncope. However, in the right context, it might be contributing factor. And the other thing is like a beta blocker as well. Like if, for what, it kind of decreases your heart rate, that affects your cardiac output. So in the right setting, it could be a contributing factor, but not the etiology of it as well. So, bradycardias are more like in a structurally normal heart are more likely to cause syncope. So that's something to think about, like making sure this patient is on telemetry to make sure you're not missing any underlying arrhythmia. So I think for him, in terms of like this repeated episode, it would be interesting to know if all of them are exertional or not. Anne Marie mentioned a good idea about like shunting. So as well, so if he ate before he went, if blood is getting shunted to his blood, or the other one to think about like subclavian still syndrome as well, that can cause shunting. So it would be helpful to know if it's like all in exertional settings or not. And then at this point, I'm wondering like, hey, if there's more than one etiology contributing to this person's syncope. Jack, what are your thoughts?
Ooh, that was absolutely brilliant, Charmaine. I really have nothing to add here. I think that like sort of an initial way of thinking about both the common things of like the structurally abnormal heart with multiple hits coming versus there being something actually out that's going to be a non-cardiac cause is absolutely phenomenal. I think for me, the biggest needle mover on the exam here is the fact that there's no murmurs, and it sounds like the prior echo, exactly as you said, showed no underlying valvular pathology. And so for me, that prioritizes one of two things. One of them is that this is an arrhythmia or that this is a non-cardiac cause, but we're going to have to falsify because of the historical factors, because of the risk factors here. We're going to have to falsify the cardiac syncope hypothesis. And so I could not agree more in terms of the importance of telemetry, as you had said, to see if we can detect one of these arrhythmias. I think the other thing is if maybe I can pull up the screen. Do you mind if I take over the screen for 1 second here? Can you all see this okay? So this is a way of thinking about potential causes of cardiac syncope, right? We have arrhythmia, structural causes, and then cardiac plus. Most of these structural causes we're going to have picked up before with a prior echo or with the physical exam, exactly as Sharmiz mentioned. And so if this is a cardiac cause, right, which we think because we think that we have some signal that there is because it was exertional syncope and it was very quickly dropped. The base rate of disease and the fact that there's no murmur on exam prioritizes the arrhythmia category. Usually it's a bradyarrhythmia, but this is somebody who has a heart rate in the 80s to the 100s on their exam. So the question is, are we dealing with a tachyarrhythmia that was paroxysmal like VT, which could be triggered in the setting of ischemia, in the setting of exertion? Or was this an SVT, which doesn't oftentimes lead to syncope, but exactly as Charmaine and Audrey told us, that can sometimes happen in the setting of hypovolemia or antihypertensive medications or some combination. So maybe we had a supraventricular tachycardia and a second hit, But what I'm most worried about is the fact that this is somebody with multiple risk factors for coronary disease who could be going into VT or some sort of ventricular arrhythmia with exertion because there is underlying CAD that potentially needs to be intervened on. So right alongside telemetry to see if we can pick up another arrhythmia, I'm wondering if this is a time where the interventional cardiologist or the cardiology consultants, if we would ask her, would you take this patient to cath, or would you do an ischemic workup in-house here to see where to go next from there? Because this is the potentially very, very morbid diagnosis that we don't want to miss in somebody with exertional syncope like this, when the echo can really help us get a good answer to the structural causes here, which we already seem to have a low probability of. So Audrey, I'm going to rely on you to teach us more about where this case went and what you learned, because we are quickly running out of real estate for my general internist mind.
Yeah, I love that, Jack. Right before we give mic back to Audrey, yeah, I love that. And the other thing to think about, like, hey, if this is always exertional syncope, can we recreate his exertion, right? Is it someone that you want to like stress us, or if you want to like walking him around and see what the telly is doing? So, if you're just like doing everything at rest, there's a good chance that you're just gonna miss if there's an underlying pathology. Back to you, Audrey.
Sounds great. Oh gosh, that's so awesome. I think it's really fascinating how much you produced with the information I provided. I guess in the interest of time, I do want to share some teaching pearls that I feel are a little cardiology specific that I did not know. And I'll just mention two things. In terms of the EKG, that was actually the biggest thing. Like you all said, we were kind of thinking the exact same things as you were, was like, does he need an ischemic workup inpatient? And should we think about it? And then we looked at the EKG, which was pretty subtle. It looked like it was sinus rhythm. But some of the things that were really pressing to our team was that he actually had somewhat of a right axis deviation, and looking kind of in leads 1 and 2, I think that's kind of what we were like saying. It was a little bit more negative. Let's see. Lead 1 was a little bit more negative, with the 2 being a little bit more positive, such that we were like, that's kind of strange. And he also had some newer on interval, like right bundle branch block morphology. And I think some of the points that I was trying to learn was that is actually there's something called a slurring S wave in like V5 and V6. I wish I could point it out to you, but those two things that were kind of slightly different in this younger patient was having us question, like, why is this person having what's going on with the conduction in the right side of his heart that is like kind of delaying conduction. And actually for those reasons, given like you said, I think we framed him as recurrent exertional syncope with this kind of new right Randall bunch morphology, we were wondering towards the lines of pulmonary hypertension. I'm trying to do a right heart cath and a left heart cath to kind of evaluate. I think it was kind of a softer call, because it wasn't like or they weren't quite sure if they should like initiate it. And so we had a big discussion about that. But given that he was kind of so symptomatic and we kind of continued it. I think what was interesting too was that on the echo, I should have explained some of the things that we learned, but there was one thing where there's no valvulopathy. I think that was clear. But in terms of like seeing any like right ventricle dysfunction, it was difficult to comment specifically on it because there was no tricuspid jet. And I think there was something about like the only way you can really measure the pressures is if there is actually a stream going in. In terms of the again, just in the interest of time, I can tell you a little bit about what they found in the right heart and left heart cath. And they did show that his mean pulmonary artery pressures were like 90, which I think the cutoff is like 25, if I recall. And so they found pulmonary hypertension, and it was as well, it was a pre-capillary pulmonary hypertension. And they also went to the left side and they saw that there was a proximal LAD stenosis at the same time, about 80%. And so we were like, oh, I think this is really interesting that he has two of these pathologies at the same time. And I also feel like there is, in terms of like, is likely the cause of at least contributing to his exertional syncope. In terms of a larger learning point, I think this was something that I realized like a lot of people were attributing to like dehydration or alcohol use in the past. And then when they did the echo, it was just like a limited study in this particular case because they couldn't really assess for pulmonary hypertension. But we were kind of like realizing like, oh, we might not have done this workup ourselves and we might have attributed to just his use. But I think what was interesting is that he had actually stabilized on naltrexone and was not drinking as much as before. So that was kind of a humbling point for me as well, to be like thinking if there's true pathology happening or if this is something that we could have overlooked.
Amazing. Audrey, thank you so much for sharing this case with us and bringing all of this fantastic teaching to really, I think, help crystallize sort of an understanding of what both the chain of events in your evaluation from a diagnostic perspective was, but also what the chain of events was in terms of how these syncopal events are happening. Like you tied it together so elegantly by bringing in both the pulmonary hypertension as well as the underlying CAD, about how both of those things could potentially come together. And as Charmaine said, it's really hard to know exactly what was happening during these episodes, but we have two very clear culprits. If we go back to the framework that we had looked at before, right? We have two very clear culprits for what could be driving the underlying hypertension. Let me pull it up again. Sorry, team. Oh, never mind. I can't, I lost the page, but on that side, in terms of pulmonary hypertension as well as underlying ischemic disease, both being primary contributors. And I think your point is so important, which is that when we are all, it's so easy to attribute any sort of new symptomatology to the plausible hypothesis of something related to substance use, but oftentimes those need to be diagnoses of exclusion before we really say it is all from, for example, in this case, alcohol use, because that can sometimes blind us to the reality that there may be intervenable processes that we can do alongside supporting this person through their substance use challenges. And it seems like that was the case here, where there was both support for alcohol use cessation alongside this really thorough and very patient-centered workup that you all went down to say, hey, wait a second, like I don't buy this as the sole explanation for these underlying syncopal events. There's enough red flag features here that we need to make sure we're not missing something else that could be contributing to these events, because this person has already done an incredible amount of work to stop drinking, and we owe it to them to complete that workup. So thank you so much. And that EKG teaching was absolutely fire. So thank you for that.
Yeah, Audrey, I couldn't agree more, Jack, with your reflections. And, I think exertional syncope, it's always warrants a workup, no matter, who the patient is, what the background is, what has done in the past. So kudos for you all not to let's diagnostic momentum and prior workup, getting away of getting to the bottom of it. And I think what is fascinating here, we're still not done with his workups. Why does he have pulmonary hypertension? So I think with his exertional syncope, I think that LAD region could be a culprit and not being helped by the pulmonary hypertension. But if he has a precapillary hypertension, then kind of thinking about, is this a group 1 pathology? Is it CTOF, or is it a group 5? So I think, Audrey, if you all are doing that workup, you have to let us know what you guys find out. And that's the beauty of medicine. We're just never done. We gotta keep digging.
Sure, Charmaine, I love that point, and I think the point that you mentioned about the workup for pulmonary hypertension, it dovetails, Audrey, with exactly what you were saying, right? The fact that this is somebody who previously used methamphetamine, it's such it is one possible culprit. And I've seen so many, and I've done this myself, of saying there is new pulmonary hypertension and there is a history of methamphetamine use. So the methamphetamine use must be the primary driver of the pulmonary hypertension. But it's not until we evaluate for all the other things that you mentioned that we can really say whether or not that's the sole driver or just one of the potential other drivers. Because I think in the same way that Audrey, you taught us the potential consequences of attributing syncope to hypovolemia from alcohol use. And it sounds like your team is certainly not going to do this, and it is an important reminder for me too to avoid this mistake of anchoring on that as a possible contributor, as opposed to saying, well, we falsified all of the other hypotheses, so it must have been the methamphetamine use. So the lessons continue to feed forward. So thank you. Oh, and you're putting some fiery pulmonary hypertension teaching in the chat. Do you want to share more about that out loud?
Oh, sure. Yeah, because I thought this was also really fun to think of the workup too. I think people were already mentioning the different types, which I think is amazing, like type 1 through 5. Type 1 is like pulmonary arterial hypertension, can be due to congenital heart disease. So thinking about shunts that are causing extra buildup of pressure on the right side. HIV, any rheumatologic disease, most of the connective tissue like scleroderma, I think was pretty common. He has no nodules or joint pain that we could assess. And then also portal hypertension, so getting a liver ultrasound for that. Type 2, I think with the left heart cath, and the right heart cath, the pulmonary wedge pressure was less than 15. So we thought that's usually like pulmonary hypertension to left heart disease. He has no signs of like overt left heart failure, as well as that pressure made type 2 less likely. We're still assessing for type 3, which is like hypertension due to like lung issues. So obstructive lung disease, restrictive lung disease. So getting like a CT chest and high res, and then like PFTs, looking for OSA, if there's any sleep study, if he snores, or that would be type 3. And then I think type 4 is kind of interesting. It's CTEPH, or chronic thromboembolic pulmonary hypertension, assessing for any history of DVTs or PEs. And really, actually, the gold standard, I think I learned this week, is VQ scans, and they have a pretty good negative predictive value. So I think it's pretty sensitive. But yeah, and then there's a lot more rare, like metabolic disorders, chronic hemolytic anemia, stuff like that. I think in type 5 that kind of captures everything else, but I think we were kind of mainly focusing on the first 4 buckets in his workup.
Audrey, you're such a boss. That was fantastic. I wish I was as good as you. You are like amazing. Just being able to take, while being so incredibly busy, like this, taking a case like this and just squeezing as much learning as possible while delivering such an amazing care to this patient. I hope you can watch this back and be very proud of all of that. It's a joy to be part of today. Thank you.
Thank you so much.
Right on. Well, I will echo Charmine's gratitude and say that I wish that I could be your intern or medical student on your team to get all of the teaching that I can only imagine you're bringing day to day. Speaking of bringing it home with teaching, I'm going to turn it over to Yasmin to bring us home with some of the awesome teaching points from this case today. But I just want to say thank you again, Audrey. This was a phenomenal presentation and really, really fun to think through. So thank you.
Yeah, it was an amazing case. Thank you so much. I think I learned so much today. And well, with this patient, we start with syncope, and the first cause we have to think about is cardiac. We can have a dysrhythmia, myocardial dysfunction, valvular heart disease. But since in this patient we didn't have a murmur, so we could suspect that it could be an arrhythmia, and then think if it was ventricular or supraventricular, and we should not miss it in any patient with syncope when it has a cardiac, we suspect of cardiac issues. Other non-cardiac issues could be reflex mediated or orthostasis mediated. The syncope can be caused by a decrease in systemic vascular resistance or cardiac output. There are also medications we have to look out in every patient that could cause this syncope, as antihypertensive, beta blockers, TCAs, or even drugs or alcohol, and such as this patient. Now, we also see that he had a right bundle branch block, and also this pulmonary wedge pressure, where we started thinking about precapillary or postcapillary pulmonary hypertension. And there are many causes. There are different types of precapillary pulmonary hypertension, mainly caused by pulmonary arterial or due to lung diseases or hypoxia, thromboembolic pulmonary hypertension, or even metabolic causes, as well as a postcapillary pulmonary hypertension caused by left heart disease. And well, this is it.
Awesome, awesome, awesome. Well, thank you everybody so much for coming out. Again, thank you, Yasmin, for the phenomenal summary of the case here. Also want to give a huge thank you to Mukund for scribing today. And then Sharmiz, it's always a blast. Thank you for soldiering through Bay Area traffic to make this happen. And one final dose of gratitude to you, Audrey, and to everybody who was here. Scrolling through the chat, it looked like it was on fire as always. And so just such an awesome way to start the morning. And I always feel so energized getting to leave you all. So thank you all so much. And I hope everyone has a great day.